This program is brought to you by Emory University.
All right, good morning, everybody. We'll go ahead and get going. This is the cardiac physical exam lecture for those that have been in the program more than a month. You may have seen this talk before. There are a few little tweaks I added this year just to change it up slightly and add a few things. But, this is a talk where I have had multiple fellows come up to me after or former fellows come up to me after they've taken the cardiology boards and say, don't ever stop doing that physical exam lecture because there was so much of it on the boards. And, when you go through and you start doing this board prep stuff, you'll see a lot of it they're not questions that are directly asking you physical exam questions. There's sort of more indirectly asking you physical exam, where they're asking about something else, but the physical exam clues are sort of key to getting the answer right. And then for the younger fellows that aren't as concerned about taking the cardiology boards yet, this really is a review of hemodynamics and the cardiac cycle and valvular disease, et cetera. So without further ado. Oops. Okay. I have no financial relationships to disclose. Okay. We're going to start with a few questions. Normally in live, we do sort of a show of hands thing, but just mentally come up with an answer, and then we'll come back to them at the end of the talk. 67-year-old male comes to see you in the office. He has a history of non-ischemic cardiomyopathy with an ejection fraction 10 to 15%. He has an ICD. He is admitted to the hospital twice in the past year for volume overload requiring intravenous diuretic therapy. At baseline, he's only able to climb one flight of stairs before he has to stop and rest. On physical exam, his blood pressure is 102/68, heart rate's 59 and regular. Jugular venous pulse is not elevated. There's no peripheral edema. He has a grade 2 holosystolic murmur at the apex, a low pitch sound and early diastole, and and I think that's at the apex as well, and a paradoxically split second heart sound. His medications are aspirin, 81 milligrams, carvedilol, 12.5 twice a day, losartan, 50, spironolactone, 25, and torsemide, 40 milligrams daily. What is the best next step in management? The classic best next step question. Would you A, increase his carvedilol from 12.5 to 25 milligrams? Would you increase his torsemide to 40 milligrams twice a day? Would you upgrade his device to CRT-D? Would you replace his mitral valve? Or would you add ivabradine to his regimen? Let's go back there. That was his blood pressure and heart rate. Grade 2 holosystolic murmur at the apex with a low pitch sound and diastole and a paradoxically split second heart sound. All right, think about what you do for that guy. We'll come back to it at the end. A college cross-country runner comes in for several months of exercise intolerance. On physical exam, she has a harsh crescendo, decrescendo murmur, loudest at the second left intercostal space. The murmur increases with inspiration. Her second heart sound is single. There's no evidence of cyanosis or clubbing. The most likely diagnosis for this patient is A, mitral valve prolapse, B, tetralogy of Fallot, C, pulmonic valve stenosis, D, severe tricuspid regurgitation due to Epstein's anomaly, or E, supravalvular aortic stenosis due to Williams syndrome. Think about what you go there. Again, we'll come back to it at the end. Third question, 22-year-old male is referred for evaluation of a murmur. Electrocardiogram shows LVH with repolarization abnormality. Physical exam, blood pressure is normal. There is a loud, late peaking systolic murmur best heard along the left sternal border. Which of the following maneuvers would make the murmur softer? Would Valsalva make the murmur softer for this condition? Would squatting make the murmur softer? Would standing make the murmur softer? Or D, would both Valsalva and squatting make this murmur softer? And finally, 66-year-old male presents with syncope. On physical exam, you notice intermittent large pulsations in the jugular veins. Intermittent meaning just every now and then, not with every cardiac cycle. This is consistent with which of the following? A, complete heart block. B, pacemaker malfunction, failure to sense. C, ventricular tachycardia. D, accelerated idioventricular rhythm. Or E, all the above can cause this finding. Okay. So again, we'll come back to all those questions at the end. The outline for this talk today, again, we're going to sort of be going through the cardiac physical exam. We'll first talk about the heart sounds, first, second, third, fourth, and extra sounds. We'll talk about murmurs, some of the more classic murmurs. We'll delve into dynamic auscultation, which is certainly a cardiology board's favorite. And then we'll finish up by talking about arterial and jugular pulsations. So the review of the cardiac physical exam, and I didn't say this at the outset, but it bears saying now that really the goal of this talk is less to make you better at the cardiac physical exam, even though that certainly may occur. You know, as your knowledge increases, your physical exam skills should certainly increase too. This is more sort of a review of the cardiac physical exam pearls that often show up on the boards, and also a review of physiology. So this is the Wigger diagram, which I'm sure you've all seen during medical school, during physiology classes. And this is really sort of what reviewing the cardiac physical exam is about. It's reviewing the timing of various events when they occur in the cardiac cycle relative to one another. And again, we'll refer to this diagram again and again as we go through the talk. All right, we're gonna start with heart sounds. The first heart sound, the often neglected first heart sound, is a result of closure of the AV valves, the mitral and tricuspid valves. It signals the start of systole. It can be single normally, but also can be split. And what's important to know is this is a physiologic finding and does not imply any pathology. A split first heart sound can be a normal finding. A loud first heart sound implies a short PR interval. And we'll circle back to this in a minute, why exactly this is. A soft first heart sound implies a long PR interval or possibly severe LV dysfunction. And variable loudness first heart sound implies variable PR interval, which you might see in Wenckebach or AV dissociation. And that's because the loudness of the first heart sound is primarily determined by the position of the mitral leaflets when mechanical systole begins. So think about the timing of when the atrial contraction is occurring versus when the ventricular contraction begins. If you have a short PR interval, you have atrial contraction quickly followed on its heels by ventricular contraction. The mitral leaflets are still relatively far apart from that atrial contraction when systole begins. So that makes a louder first heart sound. Versus when you have a long PR interval, you have your atrial contraction and then a delay, the mitral leaflets start to drift back together. And then when ventricular systole begins, the mitral leaflets are already almost touching. So the first heart sound is relatively quiet. Again, this can also happen with severe LV dysfunction when the ventricle just cannot generate the necessary force to forcefully close the mitral leaflets. So if you see loud first heart sound on a board's question, maybe they might be leading you down the WPW pathway. So think that. If they say soft first heart sound, think first degree AV block or maybe severe LV dysfunction. If they say variable, again, think something that makes the PR interval variable, like Wenckebach AV dissociation, potentially pacemaker malfunction, etc. The second heart sound, as you know, result of the closure of the aortic and pulmonic valves. It marks the end of systole. We mentioned how the first heart sound can be mildly split. Typically, when that occurs, is the mitral valve that's closing slightly before the tricuspid valve. Again, if you do have a little bit of splitting of the first heart sound, that's a normal finding. Does not mean there's no pathology there. Remember, right-sided valves, so the right side of valves, the tricuspid and pulmonic valves, they open first and close last. So under normal hemodynamic conditions, because it's a lower pressure system, those valves tend to open first and close last. Again, think of the Wigger diagram with the pressure tracings. Because of the lower pressure, less time elapses before, when at a lower pressure system, before the chambers start to equilibrate their pressures, and therefore valves open and close sooner, open sooner and then close later as a result. The converse to that is left-sided valves open last but close first. So you can see here, mitral valve closes first, aortic valve closes first under normal conditions. So again, under normal conditions, the second heart sound varies with respiration, mainly because the pulmonic component of the second heart sound moves as you inspire and expire. So under normal conditions, the aortic valve during inspiration, you pull air, but also blood into your chest. There's more filling of the right ventricle, therefore longer to eject the blood in the right ventricle. And it's probably more complicated than that. There's probably some changes in afterload in the pulmonary circulation as well, but just for purposes of memorization, just think you pull blood into the chest with inspiration, more filling of the right ventricle, takes longer to eject that blood, pulmonic closure sound is delayed. And then with expiration, pulmonic closure sound occurs earlier and generally happens right on top of the aortic closure sound. So with expiration, you have a single second heart sound, and with inspiration, you have a split second heart sound, again, under normal hemodynamic conditions. So here is a case where you have splitting of the second heart sound with both inspiration and expiration. It does not seem to be any different between the two. So this is what's known as fixed splitting of the second heart sound. And this is one of the few things in life that just really has one answer, and that's atrial septal defect. So when you see, again, on a test question, or if you hear fixed splitting, it's truly fixed, not changing at all between inspiration and expiration, again, rejoice, because there's only one answer, atrial septal defect. Nothing else does this. And this is because when you have an atrial septal defect, again, in patient with relatively normal hemodynamics without Eisenmengers, you have continuous left to right shunting at the level of the atria. Therefore, the inspiration, when a patient inspires, it doesn't really have any impact on filling of the right-sided chambers. The right-sided chambers are already sort of working at max capacity. So you breathe in a patient with ASD, and it doesn't really impact the filling of the right ventricle. It's sort of max, working at max capacity all the time. And same with you expire, does not really impact the filling of the right ventricle. It's still going to fill at max capacity. So that's fixed splitting due to an atrial septal defect. All right, here's another example. Patient has what appears to be wide splitting of the second heart sound, with the aortic component happening first and the pulmonic component happening second. But it's wide with inspiration, and then the patient expires and becomes more narrow, but never becomes single. So this is persistent or wide splitting. It varies with inspiration, but it's wide. And this is caused by something that would delay emptying of the right ventricle. So that can be an electrical cause, like a right bundle branch block, or it can be a mechanical cause like pulmonic stenosis or high afterload state from pulmonary hypertension. Now, if this was a patient with pulmonary hypertension, they may have persistent or wide splitting, and we'll get to this later, you better believe they're going to also mention that that pulmonic component of the second heart sound is loud. So they might also mention a very loud second component of the second heart sound, or loud pulmonic component of the second heart sound with pulmonary hypertension. Not necessarily so pulmonic stenosis, which we'll get to later. If anything, that may make the pulmonic component quieter. Right bundle branch block should not affect the loudness of the pulmonic component of the second heart sound, just delay it. So if it's just persistent wide splitting that varies with inspiration without any murmur or without any alterations in loudness of the pulmonic second heart sound, think right bundle branch block. All right, so here's an example of a patient with inspiration. They have a single second heart sound, and then their second heart sound splits with expiration. So this is what's known as paradoxical splitting. So this is essentially because the aortic closure sound has now been delayed, all right? The pulmonic component is still, if you can see my pointer, it's still moving back and forth with inspiration and expiration, but instead of being here, like it normally is, aortic component, the aortic component or aortic closure sound has been delayed. So again, this can be an electrical delay, like a left bundle branch block or RV pacing, or it can be a mechanical delay like aortic stenosis. So that is paradoxical splitting. So as I alluded to earlier, if normally the aortic component of the second heart sound is louder than the pulmonic component. And I didn't mention this earlier, but just to review, you can hear the aortic component of the second heart sound. You can hear it at all listening areas, regardless of where you're listening, right upper sternal border, left upper sternal border, left lower sternal border, apex. The pulmonic component under normal conditions, you can really just hear at the left upper sternal border over the pulmonic valve listening area. So that is where you would listen for splitting of the second heart sound. You should not hear this at the apex under normal conditions. Now, if a patient has pulmonary hypertension and a very loud pulmonic component, you might be able to hear it at other listening areas. And certainly if you're listening at the left upper sternal border and the pulmonic component sounds louder than the aortic component, think pulmonary hypertension. As loud or louder as the aortic component, think pulmonary hypertension. And normally the aortic component is louder at all listening areas. The pulmonic component is absent at other listening areas besides the left upper sternal border. So again, loud pulmonic component, think pulmonary hypertension. There are conditions that can also perturb the second heart sound, namely severe aortic or pulmonic stenosis. So if you have severe aortic stenosis, you may have a single or even absent second heart sound as the late peaking aortic stenosis murmur obliterates the components of the second heart sound. Here you see paradoxical splitting with a soft aortic component as aortic and pulmonic valves become stenotic. Often their closure sound becomes softer and softer as the valve becomes less and less mobile. So again, with severe aortic stenosis, you may have an absent or possibly just single as the aortic component becomes very quiet, second heart sound. And if you have severe pulmonic stenosis, you generally just have a single second heart sound as the pulmonic component of the second heart sound disappears, and you only hear the aortic component. So if you hear single second heart sound, think pulmonic stenosis or possibly aortic stenosis, depending on the murmur. Third heart sound. Third heart sounds occur in early diastole, and they occur in two very disparate populations. They occur in the very healthy athletic heart or the very sick heart. The third heart sound is caused by rapid filling of the ventricle in early diastole. Okay, and this can occur in two scenarios. One is you have a young, very healthy person, often an athletic type person, whose ventricle has wonderful diastolic function and rapidly sucks blood out of the left atrium into the ventricle during early diastole. And so you can get a third heart sound in this, again, usually young, healthy, often athletic population, versus the patient with advanced or decompensated heart failure who has very high left atrial pressure, where the blood's being pushed in rapidly due to high left atrial pressure. So again, you can have a third heart sound from blood being rapidly sucked into the left ventricle in a very healthy person, or blood being pushed in a patient with very high left atrial pressure. Fourth heart sound. So fourth heart sound does not occur in normal hearts. So unlike a third heart sound, a fourth heart sound always implies some sort of pathology. And the fourth heart sound is caused by atrial contraction against a stiff ventricle in late diastole. So if a patient has atrial fibrillation and does not have organized atrial contraction, you should not have a fourth heart sound. Whether in the real world or particularly on a board question, if a patient has chest pain and they mention a fourth heart sound, think ischemia, causing the ventricle to be transiently stiffened. So again, here in late diastole before the first heart sound, a left atrium contracting against a stiff left ventricle, causing this rapid. The exact mechanism of these sounds is thought to be essentially deceleration of flow, as again, blood is rushing into the stiff ventricle and then rapidly decelerating. All right, so we've covered the first heart sound, the second heart sound, the third heart sound, the fourth heart sound. Now we're going to get into the extra heart sounds, which certainly separate I probably can't really say the men from the boys anymore. The early fellows maybe from the more knowledgeable fellows, or certainly the fellows from the residents and the medical students. The extra sounds. Opening snap. The opening snap is caused by opening of a thickened mitral valve in early diastole, usually in someone with rheumatic mitral valve disease and mitral stenosis, okay? So again, first heart sound, second heart sound, opening snap occurs here in early diastole as a thickened, often rheumatic mitral valve pops open. One thing that's important, and they'll often ask about in this scenario, is about the interval between the second heart sound and the opening snap. In the good old days, before echocardiography was readily available to assess the severity of rheumatic mitral stenosis, and mitral stenosis was a more prevalent disease, the severity of mitral stenosis was often determined by listening to the interval between the second heart sound and the opening snap of a patient, okay? And as this interval decreases, let me say it this way, as left atrial pressure increases, mitral stenosis worsens, left atrial pressure increases, this interval will decrease. Let's remember pull up our old friend, the Wiggers diagram, to help us remember why this occurs. All right, so here is the blue line's your left ventricular tracing. There's your aortic tracing, which we're not as concerned about right now. Here's your left atrial tracing, this gray line here, okay? Here's your second heart sound, where the aortic valve closes. When the left ventricular pressure gets below aortic pressure, boom, right there, aortic valve closes. So imagine you have mitral stenosis. As your left atrial pressure increases, follow my cursor as it goes up, and you sort of work your way up this blue line, the interval between the aortic valve closure and the mitral valve opening, which occurs here when left ventricular pressure drops below left atrial pressure, that interval will decrease, all right? So think as your left atrial pressure goes up, you sort of work your way up this blue line, and this second heart sound opening snap, which occurs here, interval will decrease as mitral stenosis gets worse. That's a guaranteed board question, by the way. Write it down. Other diastolic sounds that can occur besides opening snap is the pericardial knock, which is an early diastolic sound. This is essentially the third heart sound in a patient with pericardial constriction. It's just a very loud third heart sound as the rapidly expanding ventricle um, uh, smacks up against a stiffened pericardium. So again, think of a pericardial knock as just a very loud third heart sound. And if they say the words pericardial knock on a board question, you can bet the farm that the patient has pericardial constriction. Tumor plop is another early diastolic sound in a patient with a myxoma, when the myxoma sort of obstructs flow in early diastole. I can't say that I personally ever heard a tumor plop, but again, if the question says you hear a tumor plop, you can bet they've got atrial myxoma. There are two systolic extra sounds you need to know as well. One is the ejection sound. Ejection sound is an early systolic sound made by the opening of a bicuspid aortic valve. Now, this sound may go away as a bicuspid valve becomes severely stenotic, because it is essentially this a bicuspid valve with these large, sort of almost parachute-like two leaflets popping open. It makes that sound. So as the valve becomes more stenotic, the valve doesn't really pop open anymore. It just sort of creaks open slightly. It's not going to make that sound. Interestingly, this sound is often best heard at the apex, just due to some anomalies of sound transmission in the chest. You would think you hear it best at the right upper sternal border, and sometimes you do, but often you hear this sound best at the apex. So, in the real world, sometimes you might hear an early systolic sound and think, whoa, is that a split first heart sound or whatever? And there's maybe some ambiguity. On the boards, there is never ambiguity. If they say ejection sound, they are referring to the opening of a bicuspid aortic valve. They're not going to use that terminology for anything else. So again, if you're reading the question and they say the term ejection sound, you know the patient has a bicuspid aortic valve. And again, if we go back, I'm going to go back and show. So here, by the way, is the second heart sound that occurs when left ventricular pressure exceeds left atrial pressure and the mitral valve closes and tricuspid. And then this is where an ejection sound would occur, because this is now where the aortic valve would open. Mitral valve closes, isovolumic contraction, and then boom, left ventricular pressure matches aortic pressure and aortic valve opens. So that is the gap between, that would be the gap between the second heart sound and the ejection sound. The interval between those two sounds is not as important as the opening snap second heart sound interval. The other systolic extra sound you need to know is the mid-systolic click. This is associated with mitral valve prolapse. It is caused by tensing of redundant chordae. It may or may not be associated with a late systolic murmur or mitral regurgitation. So this occurs a little bit later in systole. It's variable, and we'll talk more about dynamic auscultation later. It can occur really at any point, but generally occurs later in systole than in ejection sound. So again, if they use the term mid-systolic click, the patient has mitral valve prolapse. There's no ambiguity when it comes to the boards. Let's talk about murmurs. Aortic stenosis. The murmur of aortic stenosis, diagrammed here, is generally a crescendo, decrescendo murmur occurring in systole, best heard at the right upper sternal border. Sometimes will be associated with an ejection sound if the patient has a bicuspid valve. The most important component of the murmur in terms of determining severity is when it peaks. The more severe the aortic stenosis, the later the peak of the murmur. As we discussed earlier, as aortic stenosis gets more severe, the second heart sound can become quiet or even single or even absent in very severe aortic stenosis cases. Aortic regurgitation is a diastolic murmur diagrammed here, often a decrescendo murmur throughout diastole. Again, and often best heard along the left sternal border. Can be associated with an ejection sound if the patient has a bicuspid valve. Often they'll describe this sort of early systolic murmur. This is often to be sort of a flow murmur from high flow across the aortic valve, doesn't necessarily mean the patient has aortic stenosis. And again, the murmur tends to be decrescendo in nature. The Austin Flint murmur, something you probably will never hear in real life, but will oftentimes show up on tests. The Austin Flint murmur is a mid to late diastolic murmur heard at the apex in patients heard with severe aortic stenosis. And why do patients with severe aortic stenosis get the Austin Flint murmur? Think about the echo M-mode corollaries of severe aortic stenosis of the premature closure of the mitral valve. It's the same concept. In this, as left ventricular diastolic pressure increases with severe aortic regurgitation, it starts to push the mitral valve closed prematurely, and it can create a murmur. This can also happen if the jet is sort of directed towards the anterior leaflet and sort of pushes the anterior leaflet closed, but it's really probably more due to increased LV diastolic pressure, pushing the mitral leaflets closed. Oops. Some of the physical exam findings associated with severe aortic regurgitation is a matching game. So the Demusset sign is the head bobbing. It's the Abraham Lincoln sign. When your head bobs due to high stroke volume from severe aortic regurgitation. Quincke's pulse is when you can see pulsation in the capillary bed of the nails. Again, these are all due to very large stroke volumes from severe aortic regurgitation. Corrigan's pulse is the rapid carotid upstroke of a patient with severe aortic regurgitation. And then the de Rosier's pistol shot femoral pulse. If you take your stethoscope and apply light pressure to the femoral artery, you can sometimes hear essentially loud carotid cough sound over the femoral artery in a patient with severe regurgitation. In patient with acute severe aortic regurgitation due to endocarditis or prosthetic valve malfunction or even aortic dissection, the murmur will often be very short and early diastolic, as you can see here, due to equilibration of pressure in the left, between the aorta and the left ventricle and late diastole. So we have a short, oftentimes soft murmur in acute severe aortic regurgitation. Let's talk about congenital, pulmonic stenosis in general, but usually this is a congenital pulmonic stenosis. So this is what the murmur and auscultation of pulmonic stenosis will sound like at that left upper sternal border in patients with mild, moderate, and severe pulmonic stenosis. Notice with mild pulmonic stenosis, you have an early systolic murmur with normal splitting of the second heart sound. As it becomes more moderate, the murmur will peak later. You'll often have delayed splitting. Again, we talked about the mechanical delay, and the pulmonic component of the second heart sound will become quieter. As it becomes severe, you'll have a murmur that goes throughout systole and even a little bit into diastole, and your pulmonic closure sound, which should be here, actually will even go away with a single second heart sound. So you have a very long murmur with a single second heart sound. So again, as pulmonic stenosis becomes more severe, murmur becomes longer. Pulmonic component of the second heart sound gets softer and delayed, and then even absent as it becomes very severe. And importantly, because this is a right-sided valve lesion, the murmur increases in intensity with inspiration. As you pull more blood into the chest, the murmur will become louder with inspiration. Continuous murmur is caused often by a patent ductus arteriosus or some other type of AV fistula. Sometimes you can hear this in dialysis patients. They have a left upper arm AV fistula. The patent ductus is often best heard at the left upper sternal border. And again, it's due to continuous flow from, in the case of a patent ductus arteriosus, from the aorta into the pulmonary artery. Mitral regurgitation is a long holosystolic murmur, and if it's severe, will often be associated with a third heart sound. And if really severe, maybe oftentimes a diastolic rumble as well due to high flow across the mitral valve. I just put this arrow there just to notice just a little, technically a MR murmur often goes beyond the second heart sound. Again, let's bring up our friend, the Wigger diagram. Remember, a mitral regurgitation murmur will start here with the first. So mitral regurgitation murmur will occur anytime the LV pressure here in blue is higher than the left atrial pressure here in gray. So it starts here right at the first heart sound when the mitral valve closes, and it can go past the second heart sound, which occurs here when the aortic valve closes. So you can have the second heart sound and then still a little bit of mitral valve murmur until left ventricular pressure equals or falls below left atrial pressure. All right, dynamic auscultation. This is a very important part, so it's time to sort of wake up if you're dozing and start paying attention again, because this is stuff that, again, guaranteed to be on your boards, probably in multiple iterations. All right, first, when we talk about dynamic auscultation, we're talking about really two conditions. We're talking about hypertrophic cardiomyopathy and mitral valve prolapse, and maneuvers you can do to change the murmur of those two conditions. So let's first review various maneuvers and what physiologic changes occur with those. So hand grip. When you have a patient hand grip, essentially what you're doing is transiently increasing afterload by tensing the muscles of the upper extremities. You're transiently increasing afterload. Is it a great maneuver? I mean, it's easy to do, but you get like a tremendous increase in afterload with hand grip? Not really. You get a tremendous change in the murmur in the real world with hand grip? Not really. But just remember, it increases afterload. Valsalva is a pretty good one. Valsalva, as you know, is exhaling against a closed glottis. It increases intrathoracic pressure, and the result is you decrease preload transiently. There are various phases of the Valsalva maneuver. There's 4 phases. We're not going to, for the sake of time and sanity, we're not going to go into the 4 phases of the Valsalva maneuver today. Just know that the overall effect of the Valsalva maneuver while the patient is valsalving is it transiently decreases preload. Sort of the opposite of inspiring. It's like expiring plus. Decreased blood flowing into the chest. When a patient squats, you're doing 2 things. You're increasing afterload by kinking the vessels of the lower extremities, and you're increasing preload by compressing the veins of the lower extremities. So you get sort of a double whammy, which is why if a patient can squat in clinic, I generally have them do this as opposed to do this to make the murmur of hypertrophic cardiomyopathy softer, which we'll get to, because you get both the afterload and the preload effects. And then by standing, the opposite occurs naturally. You decrease afterload by now straightening out the vessels of the lower extremities, and you decrease preload as the veins of the lower extremities re-expand. So you get transient decrease in afterload and preload. Post-PVC, the so-called Brockenbrow effect, sort of has 2 contradictory effects, as we'll get to in a little bit. And we talk about in more detail during the hypertrophic cardiomyopathy lecture later this year. In a post-PVC beat, you have 2 things. One, you have increased preload, but you have really increased contractility, which tends to negate the effect of the increased preload. So when you think post-PVC, really remember it for the increased contractility. That's what's going on. And that's why the murmur of hypertrophic cardiomyopathy gets louder. Normally, increased preload makes the murmur of hypertrophic cardiomyopathy get softer, but the contractility effects outweigh it. And therefore, you have a louder murmur with hypertrophic cardiomyopathy. Amyl nitrite, which we don't use very much in the real world anymore, but it still shows up on tests, is essentially inhaled nitric oxide. And it is a potent afterload reducer. transient afterload reducer that you can administer to someone with hypertrophic cardiomyopathy and get dramatic increases in LVOT gradients. Oftentimes, the people who don't even have hypertrophic cardiomyopathy, it is so potent an afterload reducer. All right, but first let's talk about mitral valve prolapse. Again, first heart sound, mid-systolic click in mid-systole due to tensing of redundant chordae, and then oftentimes a murmur of mitral regurgitation after the click. So sort of the click murmur of mitral valve prolapse. So the maneuvers affect the timing of the click. So it'll move the click earlier and later in systole, and therefore the length of the murmur as well. The murmur will get softer or longer. It's not really an intensity thing. It's more of a length of the murmur can get longer or shorter with with mitral valve prolapse and maneuvers. So when you think about mitral valve prolapse, think about a valve that is too big and floppy for the ventricle in which it resides, okay? And so things that make the ventricle larger, increased preload, increased afterload, tend to make the murmur go away or make it shorter because you have a bigger ventricle that this floppy valve now fits better. The opposite occurs when you make the ventricle smaller. So when you decrease preload, decrease afterload, and the LV becomes smaller and more contractile, the ventricle gets smaller, and you're essentially making the mitral valve prolapse worse transiently because now you have this floppy valve that is even worse off for this little ventricle. So the click occurs sooner and the murmur becomes longer. And here is a graphic demonstrating this. So patient supine, let's say you have a medium-sized ventricle here, left ventricle, mid-systolic click with a late systolic murmur. Patient stands up, less preload as their legs fill with blood, the veins or legs fill with blood. The ventricle gets smaller and more contractile. The mitral valve will therefore prolapse more in this smaller ventricle with the long chordae. So the click occurs earlier and the murmur becomes longer. You have the patient squat, increase preload, increase afterload, ventricle becomes larger. The valve will prolapse less in this bigger ventricle. So the click occurs later and the murmur is shorter. Essentially, by making the ventricle larger, you're making the valve fit the ventricle better, less MR, later click, if that makes sense. Again, important concepts here. Hypertrophic cardiomyopathy also responds to maneuvers. So as opposed to mitral valve prolapse, where maneuvers affect the length of the murmur, with hypertrophic cardiomyopathy, maneuvers affect the intensity of the murmur, the loudness of the murmur, by increasing or decreasing the amount of left ventricular outflow tract obstruction. Anything that makes the ventricle smaller will bring the anterior mitral leaflet in closer contact to the septum, and therefore left ventricular outflow tract obstruction will get worse. Or anything that makes the ventricle more contractile, like a post-PVC or dobutamine, will make the ventricles smaller and therefore make the murmur worse. So increased contractility, decreased preload, anything that makes the ventricle smaller makes the murmur louder because the LVOT obstruction gets worse. Conversely, anything that makes the ventricle larger, increased preload, decreased contractility, sort of pulls the anterior mitral leaflet and the septum apart, makes LVOT obstruction less severe, and makes the murmur softer. And remember, we talked about earlier, in the post-PVC scenario where you have conflicting hemodynamic things going on, you have increased preload, which might make the ventricle bigger, but you have increased contractility after a PVC due to Starling's forces and increased intracellular calcium. Remember, contractility trumps preload in that case. So post-PVC beat, the Brockenbrough effect, again, which we'll go into more detail when we have our hypertrophic cardiomyopathy lecture. Contractility trumps the increased preload, and you have increased intensity of murmur post-PVC. So in a patient with hypertrophic cardiomyopathy, if you have them hand grip, so think through this with me, you have them hand grip, increased afterload, okay? Makes a ventricle slightly larger. The ventricle pumping gets increased afterload, larger ventricle, murmur gets softer. And I can tell you in the real world, just a skosh softer, not much in my experience. Valsalva, increase intrathoracic pressure, decrease preload, ventricle gets smaller, murmur gets louder, okay? And this one's easy to remember because if you look at the echoes of patients with hypertrophic cardiomyopathy, frequently at the end of the study, the tech will have the patient Valsalva a bunch while laying on the table to bring out more LVOT obstruction. So Valsalva makes LVOT obstruction worse, decreased preload. In the clinic, if a patient is able, I love to have them stand and squat because this will cause pretty dramatic changes in the loudness or softness of the murmur. So if you're ever in clinic seeing a patient with obstructive hypertrophic cardiomyopathy, I would implore you to have them stand and squat and listen to how it changes the murmur. It's pretty dramatic sometimes. Patient squats, increase preload, increase afterload, ventricle gets larger, murmur gets softer. Conversely, they stand up, decrease preload, decrease afterload, ventricle gets smaller, more contractile, murmur gets louder. Post PVC again, this is the Brockenbrow, another German, Brockenbrow effect. Increased contractility causes the murmur to be louder. Amyl nitrite in the imaginary world where people still use it. I think Mayo still uses it, but no one else uses it anymore because patients often will have hemodynamic collapse when you give it to them. So we tend not to use it anymore. Plus it's flammable as hell. Explosive. But on a test, you might see it. Amyl nitrite, potent afterload reducer, will make the murmur really loud. Decrease preload, increase contractility, but really from decreased preload and decreased afterload as well. Louder murmur. We'll finish up here with pulsations. These are 4 different forms of arterial pulsations that you might see. This is the normal aortic or arterial pulse wave with the dicrotic notch here, which corresponds to aortic valve closure, which is what sort of probably makes this dicrotic notch and little sort of secondary hump, which can be a normal finding. Probably not significant enough to palpate under normal circumstances, but if you have high fidelity catheter pressure tracing capability, you'll often see this in aortic or arterial pressure tracing. This one here, this high intensity arterial pulse wave form with a pronounced dicrotic notch and sort of secondary peak is known as Bisfierens pulse associated with aortic regurgitation. So again, a rapid upstroke, high intensity arterial pulsation with a predominant secondary wave, which is thought to be sort of essentially a concussion wave, early rapid ejection, and then the sort of concussion wave as the aorta sort of recoils from that large stroke volume. This is known as Bisfierens pulse. So again, if you see Bisfierens pulse on the test, think aortic regurgitation or maybe something else that causes very large stroke volume. This is the bifid, not to be confused with Bisfierens, the bifid or spike and dome pulse of hypertrophic cardiomyopathy. So you get the early rapid ejection and then obstruction sets in mid-systole and then sort of the secondary pulse wave. So you get the sort of this early peak. So this is the bifid or spike and dome pulse of obstructive hypertrophic cardiomyopathy. Then finally, the late peaking parvus et tardus pulse of severe aortic stenosis, sort of late peaking arterial waveform. So those are the sort of the big 4 arterial waveforms you need to know. Well, the big normal and the big 3, Bisfierens, bifid, and parvus et tardus pulse. Other perturbations in the arterial pulses you'll need to know: Pulsus Alternans, which is alternating large and small pulsations. This is a sign of significant LV dysfunction, sort of an end stage heart with alternating strong and weak beats. Here's a PVC interrupting the flow. but alternating strong and weak beats. This is thought to be due to abnormalities in intracellular calcium handling. It takes essentially 2 cardiac cycles to replete intracellular calcium. So you get a good beat, and then there's not enough intracellular calcium to give you a stronger beat the next beat. And then by 2 cardiac cycles later, you've restored your intracellular calcium. That's the theory anyway for Pulsus Alternans. Again, think end-stage heart failure when you hear Pulsus Alternans. Not to be confused with Pulsus Paradoxus, which is an abnormally large drop in systolic blood pressure during inspiration. Now, under normal physiologic conditions, you have a small drop. That's a normal thing to have a small drop in arterial pressure with inspiration. But if it's over 10 millimeters of mercury, that would suggest there's something abnormal going on, such as pericardial tamponade, or really any cause of increased interventricular interdependence. Essentially, what's happening with Pulsus Paradoxus is as someone inspires and they're pulling more blood into the right ventricle, it is impinging upon left ventricular filling in the case of pericardial tamponade, where you have pericardial fluid pushing on the heart, or you can even see this in pericardial constriction or with severe RV dysfunction, where the RV is pressing on the LV. So anything, I mean, it's again, most commonly associated with pericardial tamponade, but really anything that causes increased interventricular interdependence, you can see Pulsus Paradoxus, which again is a drop in systolic pressure of 10 millimeters of mercury or more with inspiration. It's an exaggeration of a normal physiologic occurrence. Again, not to be confused with Pulsus Alternans, which is also not to be confused with electrical alternans, which is the electrical beat-to-beat changes you often see in patients with large pericardial fusions, often tamponade, okay? So the naming of these things is incredibly confusing and similar. So remember, electrical alternans, beat-to-beat changes in the QRS amplitude on EKG. This is not a physical exam thing. I know we're sort of going off topic, but electrical alternans often happens at the same time Pulsus Paradoxus happens, and is different from Pulsus Alternans, which is in severe LV dysfunction. So keep them straight out there. Pulsus Alternans, severe LV dysfunction; Pulsus Paradoxus, tamponade or something else causing interventricular interdependence; electrical alternans. This is pretty unique to large pericardial fusion, often with pericardial tamponade. So the swinging heart in a large pericardial fusion. Okay, we'll talk last about jugular venous pulse. This is the normal jugular venous waveform. So think of this also as a right atrial pressure tracing, similar. You have the A wave, which corresponds with the first heart sound. When the right atrium contracts, you get an increase in jugular venous pulse. You might be able to see a little C wave here, particularly if you have a catheter measuring pressures. The C wave corresponds with tricuspid valve closure, and there's often a little temporal delay between the first heart sound and when you see the C wave in the jugular vein because of the distance between the two. The X descent, so you have atrial contraction, and then the X descent as the atrial right atrium relaxes, and then you have the V wave as the right atrium fills. Then they have the Y descent in early diastole as the right atrium empties into the ventricle. So again, atrial contraction, atrial relaxation, atrial filling, atrial emptying. AX, then VY. X descent, Y descent, A wave, V wave. V wave generally corresponds with roughly the second heart sound. Now, I want to do something interesting here and superimpose, if I can get it to come, it might be frozen here. There it is. I was gonna superimpose pulmonary venous flow on top of jugular venous pulse. For those of you who've done a few echo months and have studied pulmonary venous flow into the atria, this would be into the left atrium, obviously, but notice how it sort of mirrors jugular venous pulse wave. You have the atrial contraction here, corresponds with the A wave. So atria contracts, blood will go backwards. Again, now we're talking sort of about the left atrium. But the atrium contracts, blood goes backwards into the pulmonary vein, and then blood flows out of the pulmonary vein into the left atrium as the atrium relaxes. And then as the left atrium fills, you get decreased flow out of the pulmonary veins. And then as the left atrium empties, you have increased flow back into the left atrium. So as the atrial pressure goes down, pulmonary vein flow goes up. And as atrial pressure goes up, pulmonary venous flow goes down, or even becomes inverted when the atria contracts. Just putting all that together to understand atrial pressure. And advance. Okay. In the jugular venous pulse, when you see, when the test says a patient has large A waves, and this is the terminology they will use, they don't mince their words. The patient has large A waves, that refers to a stiff right ventricle. So think pulmonic valve stenosis, pulmonary hypertension. If you see giant A waves, which are even bigger, so there's large and then there's giant. If you have giant A waves, think tricuspid valve stenosis, which creates even bigger A waves. So again, the right atrium contracting gets a stiff ventricle, you get large A waves in the jugular venous pulse. Atrium contracting against a stenotic tricuspid valve, you get even bigger A waves. If you see cannon A waves occur when there's AV dissociation. That is the right atrium contracting against a closed tricuspid valve. So this occurs with AV dissociation. The important point about cannon A waves is they do not occur with every cardiac cycle because the timing has to be right. So when the atria contracts against a closed tricuspid valve with AV dissociation, you'll get a cannon A wave, and those are intermittent, not with every cardiac cycle. These will be with every cardiac cycle, large and giant, but cannon A waves will be intermittent. Large V waves occur with tricuspid regurgitation as right atrial pressure goes up during systole. If they mention there's a deep Y descent, think constriction. As we go back, because that'll be steep Y descent here, early rapid filling of the right ventricle. Think constriction. Blunted Y descent, think tamponade, because you cannot fill the right ventricle during early diastole due to pericardial fluid. All right, in our last 2 minutes here, we'll get back to our questions. This is a 67-year-old male with non-ischemic cardiomyopathy. And he's got murmur mitral regurgitation, possibly severe because he has this low pitch sound in early diastole, or maybe he has a thickened valve, a little bit of stenosis, mitral stenosis, but he has a paradoxically split second heart sound suggesting possibly a left bundle branch block. So this guy's been in the hospital despite good medical management with a left bundle branch block, upgrade to CRT. I did my board recertification 2 years ago. I got asked this question in some form or fashion, like 3 different ways. That if a patient has a left bundle and heart failure that's not doing well despite optimal medical therapy, by all means, please upgrade him to CRT-D. This is the cross-country runner with harsh crescendo decrescendo murmur at the left upper sternal border, murmur increase with inspiration, single second heart sound. This patient has congenital pulmonic valve stenosis. Why is this not mitral valve prolapse? Well, it's a crescendo decrescendo murmur heard up the left upper sternal border. That's not mitral valve prolapse. Why isn't it tetralogy flow? You could have a similar murmur with tetralogy, but I mentioned there's no evidence of sinus or clubbing, so probably not going to have tetralogy. Why is this not severe TR? Well, first, it's a crescendo decrescendo murmur. Severe TR tends to be holosystolic murmur. It does increase with inspiration, which TR might. And there's a single second heart sound. Ebstein's anomaly, you should have normal second heart sound. And it's not supravalvular stenosis due to Williams syndrome, mainly because the murmur changes to inspiration. It's sort of the left upper sternal border, and the second heart sound is single. You should have a normal second heart sound with supravalvular aortic stenosis. Patient with hypertrophic cardiomyopathy, which would make the murmur softer, squatting, increasing preload, increasing afterload should make the murmur softer. Valsalva and standing will make it louder. 66-year-old male with syncope. He has intermittent large pulsations of the jugular veins. He has canon A waves. This is consistent with which of the following? Complete heart block? Yes. Pacemaker malfunction? Sure. AV dissociation. Ventricular tachycardia? Yep. You can have AV dissociation with ventricular tachycardia if the atria continue to contract. Accelerated idioventricular rhythm? Yep. Another form of AV dissociation. So yes, all the above. So it occurs again when the right atrium contracts against a closed tricuspid valve. You get the canon A waves. Any questions about this talk from the group? Thank you.
The preceding program is copyrighted by Emory University.